wonderful to see so many people on the call. And this is a webinar talking about care provider workforce risk assessments, particularly in light of keeping our staff safe during COVID-19. And the premise is to make it very practical. So we've got some amazing speakers sharing not only the regional context, but then some real practical examples, hopefully that you'll all find incredibly useful. So this webinar is hosted by Healthy London Partnership and NHS London, but you'll be able to see from the number of logos across the top, it is being developed in partnership with a whole range of wonderful partners. So moving on to the next slide, James, and I'll introduce myself. So my name's Bryony Sloper and I'm chairing today's webinar, and I lead the out of hospital cell for the London region, particularly leading areas such as ageing well and discharge and community services. Just a reminder for everybody to put themselves on mute, and please turn your cameras off unless you're presenting. And another reminder for those people just joined us that the webinar is being recorded, and we will share the recording after today. If you didn't join by Eventbrite, we won't have your contact details, so do feel free to either post your email in the chat or to email. I think Ezra has put in the Enhanced Health and Care Home email address, and please then we can make sure that you receive the recording. So we've got a wonderful team hosting us today. Ezra as our Enhanced Health and Care Homes lead. We've got Aileen from ADAS. Dan is keeping an eye on the chat as we go, and we've got James who's going to be hosting our Q&A. So we go on to the next slide, and I'll give some housekeeping. So as we run through the agenda, and it is very tight, recognising we only have an hour, as people have questions, please post those in the chat and we'll collate those and we'll then share those with the question and answer panel at the end. So you have 4 fabulous presenters. Janine, who will be talking through the regional context. We've got Sue, who's going to speak from a national provider, multi-site provider perspective. Carly, talking about domiciliary care. And Priscilla, who's from Sue-Ann from Priscilla Wakefield House, who will talk from the perspective of a small local provider, and then a Q&A. So hopefully we'll run to time. Please, again, remember, keep yourself on mute, turn off your camera unless you're speaking, and put your questions into the chat, and I think we'll get started. So I'm going to hand over to our first speaker. Next slide, please, James. Oh, this is covered. I've already covered. So handing over to Janine LaRosa, the Head of Equality and Inclusion, NHS England and Improvement. Janine, over to you.
Hello, thank you so much, Bryony, for inviting me to come and talk to you all today. Yes, so I'm Head of Equality and Inclusion for London, and I was really keen to come and talk to you about the work that we've been doing within the region to keep the staff working within the NHS safe during COVID, because as we know, early on it was recognised that there is a disproportionate impact of COVID-19 on people from Black, Asian, minority ethnic backgrounds, but also over time the number of additional groups that are at risk, including age, weight, pregnancy and underlying conditions. So if we go on to the first slide, please, James. Right, so in my role as risk assessment lead for the region, what was very clear, actually James, if we can go back up one, because I'm going to do a bit more of an intro. What was very clear was that, yes, there was that disproportionate impact, but when we first started to offer risk assessments to our people, they were banded as being BAME risk assessments. And what we found was that actually the uptake of those risk assessments was much lower than we would have expected. So the work that I've been doing is to develop a model for London, which I'm going to share with you now. If we can go to the next slide. So this is essentially a model or a checklist, and so we have 3 pillars here. The first pillar is around workforce risk management, and what I'm thinking about there is that we understand within the demographics for London, I'm talking NHS in particular, that 44.9% of our staff are from a Black, Asian, minority ethnic background. But when you break that down into an organisational level, we know that there are some organisations where the proportion of BAME staff is much higher. And we also know that within London, we have more Black, Asian and minority ethnic nurses than we have white nurses. So it was very important that early on organisations understand that risk profile, and also breaking down by age and what they know in terms of other protected characteristics. So it's very important that they understood that information and were able to have effective ways of understanding and tracking their staff COVID-19 status. And there were some really wonderful examples of best practice. So for example, London Ambulance Service, when staff informed them that they were self-isolating, that they arranged for food parcels to be delivered to people. So really showing support. But then also, by understanding that information, being able to develop and offer operational plans. So what that's thinking about is, so I'm aware of some community services which were 80% BAME, of which probably about half of that team were over the age of 50. So therefore, very high risk potentially. Sorry, someone needs to go on mute. Sorry, I'm getting quite a bit of background noise. So potentially very high risk. So in developing those operational plans, to demonstrate to staff that services could keep running, it helped to give staff assurance that if they do put themselves forward for risk assessment, that does not mean that if they are high risk that the service would stop. What we were able to see was that many services were adjusted to mitigate the risk, including thinking about, so for example, if you're running a service where you're changing dressings, for example, it's ensuring that you've got all of the equipment out and ready before the patient walks into the room, thereby reducing the amount of time where you have that face-to-face contact. And then also ensuring that at a workforce level, we have processes in place to conduct those individual risk assessments and action those operational plans as necessary. And then we had the middle pillar, which I think is the most important, and that's the role of the line manager or supervisor as that primary point of contact. And so within the London context, what we've been very keen to avoid is risk assessments becoming a tick box. So we weren't advocating at a regional level the use of apps or anything like that. What we wanted was to ensure that line managers were having those direct one-to-one conversations with their people, because this offered an opportunity to check in more widely around how staff were experiencing the first wave of COVID, you know, understanding if they had any other concerns, be outside of work, that were impacting them, and giving that opportunity for pastoral care, because we know this has been a very stressful time for all of our people. So as well as keeping people safe in terms of identifying and mitigating risk, there was a wider well-being and resilience conversation. And then line managers, so for lots of their staff, it might be quite a short conversation in terms of the risk assessment piece, but there may be other staff members who perhaps have more complex conditions, or where mitigation may not be as readily identifiable, in which case they were engaging with occupational health to understand what a full risk assessment might look like and ensure that that is carried out. And line managers also play a really important role, which is around closing that loop in terms of feedback. So any concerns raised, for example, around PPE, ensuring that they are noted and actioned. And then the final piece, which is an ongoing and critical piece of work, is around how we engage and talk to our people and ensure that their concerns are validated and actioned. So closing that feedback loop around people they share their stories and experiences, but what do we then do? So what we're looking at there is, we'll have seen, and I'm sure in lots of your organisations it would have been similar, key messages around COVID and the impact on our people, and also due to the tragic death of George Floyd and the increased awareness of Black Lives Matter, lots of messages of support and endorsement there coming from our senior leaders. So recognising and validating our people's concerns. And it's important that as time moves on, that does not stop. And then also, this has been an opportunity to engage with our staff network. So listening to our people, ensuring that they are involved in decision making and being able to give that feedback. And of course, we've got other methods, so pulse surveys, listening events, and other methods of gathering staff feedback. And together, all of those together, I think, have helped us to build trust, have helped us to ensure that what we're offering within the region actually meets the needs of our people. So one of the examples that I can give around how we've listened and actioned is around the fact that some staff were saying, actually, I don't think I can have a risk assessment because I know that I might be high risk. And if I'm redeployed away from my role and into another employer potentially, that might mean that I actually lose my tier 2 visa. So for that individual, they've done their own individual risk assessment and said actually the risk to their family and their family stability might be greater around engaging with the risk assessment process than not. But we were able to provide assurance to people that we would be looking to not redeploy unless absolutely necessary, and that where people were redeployed as a result of their COVID risk, they would remain with the same employer, thereby not impacting on visa status. So I think it's very important to listen and understand people's concerns. And then going on to the next slide, I'm conscious of time. What we do have available, and this was obviously what we're doing in the NHS, but this is the Faculty of Medicine framework, which is available to everyone on the NHS employers website, and I'm sure we'll put that in the chat as well. And what this does is similar to the model I've just shown you, which is where we have the assessment of the workplace. What is it that people are doing? What are the systems of work? Is there a way we can make that more safe for people? That assessment of the workforce, so who are the individuals who are most at risk and how might you support them? And then also the assessment of the individual. And as time moves on, my consideration now is turning to how do we operationalize this, looking at things like do we look to have COVID passports that go with people, particularly thinking about our bank and temporary staff with this, so people understand what their individual risk is and they can make that clear to their managers. But this framework is available on NHS employers, along with, I think, some of our wonderful best practice examples. Within London, we did not have a single recommended risk assessment template. Rather, what I was doing was ensuring that each organisation had a risk assessment template that worked for them and the services that they offered, that was aligned with the best practice coming out of tools such as this framework, and making sure that where we had particular examples of best practice, that they were being shared. So the Guy's and St Thomas's risk assessment process is on NHS employers, including the template, the manager's guidance, and also the employee guidance as well. And I'm going to stop there. Thank you, Bryony.
Thank you so much, Janine, setting out that context. So we're going to move on to our next speaker. Just for those who've joined, please put your questions in the chat box as we go, as our speakers go. Please keep yourself on mute, and please be advised the webinar is being recorded so we can share it afterwards. And moving on to Sue, thank you so much. Sue's the head of health and safety for HC1, and she's going to share their experiences. Thank you, Sue.
Well, good afternoon, everybody, and I'm so pleased to be able to be here this afternoon to share some of the best practice that we've been undertaking in HC1 with regard to COVID workforce risk assessment. So first of all, there was a few challenges for us. HC1 is one of the largest providers of health and social care in the UK. We operate out of 320 or so sites across England, Wales and Scotland, and employ a diverse workforce of around 23,000 staff. Now, with that, we don't keep ethnicity data. And our medical information with regard to staff is probably a little bit out of date, bearing in mind it would have been submitted when they joined the organisation. Following on from that, the other challenge that was put to me was, well, which risk assessment tool should we use? So I was tasked with looking at different techniques employed within the NHS and also in private sector, and from my own personal experience of working in health and safety. And there was lots to choose from, and it was whether we had a narrative or a numerical system, but taking into consideration, we didn't have time to roll out a sophisticated training program, and it would have to be something that our colleagues could understand, could implement, and would actually achieve the end result we wanted to. So that needed to be backed up by a communication strategy to really, you know, drill home that the workforce risk assessment was of value to individuals and to engage trust in that process. So moving on from that, with regard to considerations, basically keep it simple. That would be my best advice. If you start playing about with numbers, you often then increase the error factor. Also, in doing risk assessment, assigning a numerical value to complex health conditions and comorbidities is quite difficult. We also needed to provide independent advice and assurance on the process. So we did engage with other independent bodies provided by sort of the Employee Assistance Programme and from our occupational health provider service. So in terms of the implementation strategy, what we did was we had a very high level committee that primarily were looking after the best interests of our BAME communities. However, that remit was extended to everybody within the organisation.
Can everybody go on mute, please, if you're not presenting?
Thank you, Bryony. So we then went out for consultation with regard to our proposal to all our operational managers, and we consulted our recognised trade union, which is the GMB. We sent individual letters to 18,000 employees, including wellbeing details and sort of the independent channels for further information and support. We had a series of webinars such as this that were delivered to our managers, explaining the process, what action was required and timescale. And in the background of all of this, our wonderful IT team were working on an electronic tool that would translate the paper format into an online system so we could monitor progress of the risk assessments and have some transparency and oversight with regard to completion of the process. And this really was important to actually identify homes that were struggling, that really did need some extra support, so we could help them on the way. Now, the next slide actually covers the 5 steps to the process, and it's rather a little bit small on the slide, so I'm going to skip that and come back to it if anybody does have any questions. But the key actions are on the next slide, and really it's straightforward. Everybody and anybody in the organisation, regardless of whether you were a senior manager or sort of most junior member of the team, you had to complete a questionnaire. So the questionnaire looked at ethnicity and it looked at underlying health conditions that would be a criteria to put you in a higher risk category. So the questionnaire is completed, sent to the line manager. It's then evaluated, and if in fact you score a moderate or significant risk, then the next stage comes on board, which is an individual face-to-face conversation with the line manager to say, look, you've scored moderate or significant. Let's consider your role and what risk mitigation actions we can put in place. So we designed a standard hierarchy of control measures just as a starting point for managers to consider. It's by no means exhaustive, and we welcome ideas from all over the business. But it was just so that we could get some consistency in approach in the early days. We also made support available by our HR teams and the health and safety teams. And the caveat to all of this, which was absolutely pinnacle, was that we really wanted to give our colleagues assurance that this was not a process to try and move them on to other jobs, and redeployment would be the very last resort. So just focusing on risk controls to give you a flavour of what was put in place. We implemented flexible start and finish times so that higher risk colleagues could travel outside of peak period. We also encouraged healthy practices such as walking to work, cycling to work, and assisted them to do so if they wish to. We insisted on 2 metre social distancing at all times, wherever that was possible. Obviously, we're in a care delivery position, so where that wasn't feasible, we had to introduce further risk mitigations. Now, our protection and prevention plan in HC1 is a RAG rated system, and basically we rely on weekly testing of all COVIDs and testing of residents at least every 28 days. So if we have a green home, that means that the home has been free of COVID for 28 days. But within that, we may have an amber area. So this means we've had a new admission to the service. So the new resident moving in with us would be tested on discharge from the NHS, retested when they join us at the home, kept in social isolation for 14 days until the clear. And then once they've been cleared of any COVID, they will be allowed to then socialise with the rest of the people in the home. And if it's a red zone, that means that we have got a COVID positive case. And where we have that situation, then only low risk colleagues will be allowed to administer care in that area. So that's how our RAG rating system operates. In addition to that, we've introduced cohort working. And what we try and do is roster higher risk colleagues on the busier shifts, i.e. during the day shift rather than the night shift. This allows us a flexibility to delegate the tasks better because we've got more people, we've got more resources available during the day than we do on the night shift. We also limit close interaction with our colleagues by preparing things outside of that 1 metre zone as much as we possibly can, has been mentioned, I think, by Janine. We try and delegate the high risk activities to lower risk colleagues. We ensure that the prescribed PPE is worn at all times. We undertake spot checks in all our homes, including night visits by our central services teams to ensure adherence to the company PPE policy. We encourage our colleagues to take regular breaks, more than they would do before the pandemic. If they need to remove themselves from a work area to outside of the home to get a breath of fresh air, remove their PPE, that is perfectly acceptable. And we do encourage the PPE to be refreshed as regularly as necessary. Where we can, it's not always feasible, but where we can and we know residents are cooperative, we would also encourage them to wear a surgical face mask during close interaction. We perform very few aerosol generating procedures within the business, but our nursing services do deliver those. So we've introduced, obviously, guidance in accordance with the NHS that only low risk colleagues must be involved with AGPs. Moving on, we considered emergency.
So it's Bryony, apologies. It's 1 minute warning.
Okay, that's fine. I've nearly finished, Bryony. Thank you for the warning. Emergency situations, okay, high risk colleagues not to intervene with obviously mouth to mouth or indeed first aid, and redeployment would be a last resort. For those that are very high risk, we would consider working from home and support colleagues to continue to do so with equipment and furniture. So it brings me to my last slide, and in effect, the programme is continuing. We've now got videos online to help our colleagues through the process. The support continues from essential services, and we remain fully committed. Unfortunately, COVID is here for the long term, and we see this as being very much a marathon and not a sprint, but we will get there eventually. Thank you.
Thank you so much, Sue. That's brilliant. I realise we are running over time, so I'm going to move us swiftly on to Carly. Thanks, Carly, who's the registered manager at the Lodge group at Care UK. And please do, people, put any questions in the chat so that we can pick up with the panel later. Over to you, Carly. Thank you. Carly, are you there? If we've lost Carly.
No, I was talking away and I was muted. So anyway, so Carly Rochester here. I'm the registered manager for Lodge Group Care. I've worked in health and social care for the past 20 years. I've been the registered manager of Lodge Group for the past 10 years. Our agency has 200 clients and 110 care workers servicing around 2,500 hours of care. We have a diverse workforce that works across the borough of Havering. So what was already in place for us pre-COVID? So we had a business continuity plan, an employment assistant programme, electronic care plans and log records, electronic rotas, a rated risk assessment, and area-based senior care workers. Next slide, please. So the challenges during the COVID-19 outbreak. So it was the lack of testing for both clients and carers, having to allocate 2 staff to place their full-time attention on acquiring sufficient PPE to support the workforce, no control over who people had in their property, and at times this was against government guidance, having a scared and anxious workforce, having concerned family members about care staff potentially being the spreaders of COVID-19 to their loved ones, having a remote workforce, insufficient care and support levels for clients no longer at day centres, the remoteness of our clients, our office team with a variant of medical conditions being a risk to one another, mobilisation of the workforce, appropriate disposal of full PPE, and training all the workforce on COVID-19 with little to no information initially. So what did we do? Our RAG rating tool was reviewed in lines of the risks of COVID-19. Our business continuity plan was revised to include the COVID-19 outbreak. We updated our infection control policy to include COVID-19. We issued a new infection control, easy to read guidance with step-by-step measures. We shut the office and sent all the internal staff home to work remotely to minimise any disruptions of service should there be an internal COVID-19 outbreak. We commissioned, where needed and possible, extra calls for clients now at risk due to withdrawal of other services. From the start to allay all concerns, we asked all staff to wear full PPE. We issued COVID-19 kits to every staff member. We purchased emergency food supplies for the most at-risk clients. We also provided emergency food parcels to clients who shop online and was now facing 3-week waits for delivery slots. We set up 4 PPE mobile stations across the borough for carers to gain easy access to PPE at all times. We set up a COVID-19 information hub on WhatsApp to issue all guidance when it was published for carers to have a central reference point to look at. We set every carer and client up with an identified team leader who carries out wellbeing calls weekly to check everyone has what they need and they feel well supported. We also commissioned 2 drivers who worked across the borough to support the care workers with mobilisation. We did a video of what PPE carers should always be wearing, with myself narrating and an office member demonstrating to give staff teams a personal touch. Included in our weekly calls that care staff should listen to government announcements and read all the guidance issued rather than media outlets that were creating hysteria. We also set up a specific COVID-19 team to provide the care and support for people with confirmed COVID-19. We carried out specific BAME risk assessments. We spoke to each individual separately to ensure they felt supported and safe. We closely worked with our local authority, brokerage team, social workers, hospital discharge team, and safeguarding teams alike. And after a few months in lockdown, we as a team got together, socially distanced of course, and we made 200 home cooked roast dinners for our clients, people that were missing family, just to lift some community spirit and let them know we are all in this together. Ongoing challenges have been testing is more difficult to obtain for care staff because of demand. PPE is at inflated prices and can sometimes be delivered at poor quality. The continuing high cost to the agency to support all the changes that we have had to implement. Complacency of client and family members not following government rules. Ensuring that there is no complacency amongst staff with COVID-19 and that they are wearing full PPE and still following all of the guidance. For home care, for domiciliary care, there is no systemic testing process in place. No government focus on community care. The focus is clearly around residential and nursing care. We are continually reviewing.
Could everyone please go on mute? Thank you.
I'll just carry on. We're continually reviewing the
I think, Carla, you might be on mute if you can hear me there.
Yes, I think someone's done mute all, and we just need to mute the individual participant.
Okay, so I'll start from our ongoing challenges. So testing is more difficult to obtain for care staff because of demand. PPE inflated prices and can come in poor quality. The continuing high cost to the agency to support all changes we have had to implement. Complacency of clients and family members not following government rules. Ensuring there is no complacency among staff and with COVID-19, and they are wearing full PPE and still following the guidance. There's no systemic testing process in place for home care services. Government focus on don't focus on community care. Purely focus is around residential and nursing care. Continually, we are reviewing our business continuity plan in line with new and increasing community infections. Test and trace of staff members and ensuring correct people are isolating. We have a watch list of actions, and we have to undertake and reassess those in line with challenges that arise from new infection. And obviously it's respiratory season is fast approaching, and the challenges that we'll face on the service and the worry that will start from staff and clients alike that a common cold or seasonal flu could be COVID-19. So I'll just finish my presentation with some quotes from our BAME workforce. There's two. So the first one is, Lodge Group Care have made me feel valued and important throughout the COVID-19 pandemic. I have always received PPE in a timely fashion to ensure I am safe. I am fully informed of what the policy and procedures are in terms of infection control. I have had full support from my team leader on a weekly basis. The biggest compliment I can give my employer is, I have felt safe in an unsafe time. And that was from Patricia O, from one of our senior carers. And the second one, just to finish everything off, is I have an underlying health condition. I was not shielded, but my family members and myself were worried for me. Lodge Group provided me with full PPE, refresher infection control courses, COVID-19 training course, COVID-19 kit of not only PPE but disinfectant wipes for the areas I touch. I have never felt that I didn't know what was going on, because we have an information hub, and I have a team leader who I speak to weekly. Because I am a walker, I was provided transport support. This allayed my fears of getting on a bus, travelling to clients. This also mitigated some of the risk of me being exposed to community infection. Lodge Group Care value me, and I value them for caring. Thank you.
Thank you so much, Carly. That was really inspiring. Again, some really practical examples of what providers can do. Recognising we're running really short of time, so I'm handing over now to Sue Ann Namani, who's the General Manager at Priscilla Wakefield House. Over to you.
Hi everyone, if I can get James to just click on to the next slide. So Priscilla Wakefield House is a nursing home located in Tottenham, and we are a 117 bedded nursing home. Next slide. We have 180 employees, of which, indicative of the area, is a very diverse workforce. And what was already in place pre-COVID was obviously we have an electronic care planning system that we use for risk assessing and monitoring, and we also had robust care plans in place for individuals, as well as we had quite a lot of knowledge about our ethnicity of our staff and their medical conditions. We have risk assessments that were face-to-face on a one-to-one basis, and direct reporting tools which were completed regularly for updates to our line managers. We hosted wellbeing cafes on a weekly basis, and this was just to touch base with staff to see what their anxieties were and to support them in reducing stress levels due to COVID-19. In-house, we have 10 mental health first aiders, which were the ones that were hosting these events. And if staff didn't yet still feel confident, we also offered them the employee assistance program, which for many they did take up because there was also additional support around cognitive behavioral therapy. We had a robust business continuity plan in place, which was shared with the local authority, the CCG, and our CQC inspector, and it was continually updated as things changed. Next slide. So some of the challenges during COVID peak was increased admissions from hospital, where usually you'll get a client back in the home when they're medically optimized. We saw that that wasn't happening. So a lot of the clients were coming back very close to end of life. And as a GSF nursing home, we were able to support the end of life process. But one of the major challenges was not having the COVID testing results prior to discharges from hospitals. We also weren't able to access PPE from our general suppliers due to prioritization of the NHS. And we saw that we struggled quite a lot with the basic PPE, which we had before. And on top of that, the new PPE guidelines around the fit testing, FFP3 masks, etc. However, we did get some support from our local authority when it came to crunch time. There was also lack of testing, which resulted in an inability to control the spread of the virus. So whereby we saw very early on a heightened number of deaths, we weren't able to get the testing quick enough to be able to stop the spread within the nursing home. There was also a lack of clarity around BAME and how to support high-risk staff during the pandemic. And then social care workers, as I'm sure we all agree, felt not as cared for as our NHS colleagues. So what did we do? We worked collaboratively with the CCG colleagues within North Central London and Haringey local authorities. We adopted tools from the NHS Trust to carry out risk assessments for our BAME staff and also vulnerable staff, which were those who were pregnant and had other underlying medical condition. We worked in conjunction with line managers to just identify clusters of staff that would be at risk, and in the event of an outbreak, how we would support them. Mental health first aiders were on hand and on site to just support with loss, because as we all consider the individuals we support a part of our family, there was quite a significant amount of loss during that time. Also with financial pressures and stress relating to work in such an environment, i.e. around COVID. We started holding weekly wellness sessions, which still we continue to do that, and carried out mental health first aid, giving staff opportunity to meet on a one-to-one basis. Issues were raised, around discussion, and we shared that with our line management structure, and that was acted on and feedback given to staff via meetings and supervisions. We also continued to update our business continuity plan, specifically in view of COVID-19, and we're now working on updating that yet again in collaboration with our local authority and CCG for a second wave of the virus. We also have an employee assistance program to support staff through life issues, and during the peak they felt that that was very supportive and they gained a lot from it. Next slide. Some of the outcomes: so better protected workforce, which is as a result of the tools used to assess risk. We had good engagement with staff via regular meetings, such as our wellness CAFs, and these were done in small groups, but also included one-to-one sessions for those that needed it. We increased access to testing and ongoing support to continue testing for staff and residents, and this gave the staff the level of confidence they needed, which made them less anxious as a result. We carried out BAME risk assessments for all our staff, both those who are BAME, but we also made it an educational tool for those who weren't under those categories, but who understood the levels of heightened risk that BAME staff would have been under. The care home received a good rating from the CQC focused inspection on infection control. And the next slide, I'll just share just a couple of the points that were raised there. So they felt that the staff was supported with training infection control. And when the inspector came around for the focus inspection, she felt that all in all, the home was extremely good at supporting staff with infection control practices within the environment. I'll just switch to the next slide. Ongoing challenges. Nurse recruitment remains a huge challenge. It was pre-COVID, and then now during, it's even harder as border closures has meant that the staff who we were recruiting externally are now still in limbo in terms of coming into the country. There's also isolation timeframes, which makes it difficult to recruit overseas nurses. Access to certain types of PPE, which changes obviously regularly. So sometimes you're able to access such PPE and sometimes you're not. ongoing issues with testing and results obviously still taking too long. We are in partnership with North Central London, where care providers, we had an action review, which is around learning lessons from what happened during COVID, and then obviously preparing if there is a second wave of the virus to have a robust contingency for those sorts of issues that are ongoing. I think that brings me to my last slide. Or is there? Yeah, thank you.
Absolutely brilliant, Sue-Ann, thank you so much. So that brings us to the final section of the webinar, which is an opportunity to put questions to our panelists. And John will be just sharing that. We've just, James, we've just lost the slide with all the pictures on.
Bear with me. Let's see if we can get that back.
Yeah, fantastic. So we've got all of our presenters available. I'm amazed there haven't been more questions in the chat, actually. So all of our presenters who you've been introduced to, but we've also got a range of specialists, as you can see all their beautiful pictures lined up there at the bottom. So please, I think, James, we've already got a couple of questions. Are you happy to start the discussion?
Yeah, absolutely. And I know that we are quite tight on time, and some will need to leave at 2 o'clock. So we've had a fantastic question come in from Henneke Uddin, and I think possibly it's a good opportunity to go around the whole panel. I'll let you put your hands up to go first. But the question is, what were the greatest challenges you all faced, and how were they overcome? Maybe we could go to Janine first on that one.
Okay. Hopefully you can all hear me. My neighbour decided to do some drilling, so I'll try and raise my voice. So I think the biggest challenge that I had within the region was pivoting away from the focus on risk assessments being for BAME staff, because on hearing that, I think that had a negative impact in terms of people being willing to take them up, and I think that highlighted some further issues around trust that we needed to work on. But pivoting towards it being around keeping all of our staff safe has been really successful. And actually, we've now found that 97% of all of the staff who work within London have had a risk assessment. So that's worked really well. But I think it was important for us to recognise and call out that targeting BAME was a barrier.
Excellent, thanks, Janine. Sue-Ann, I know that you might need to leave us 2 p.m. sharp, so I'm going to come to you next. What were your greatest challenges, and how did you overcome them? Maybe you could give us a bit more detail on what you've already shared in your slides.
Sure. One of the greatest challenges was around the access to PPE, because suddenly you had suppliers who were telling you they didn't have the PPE that you required or that you've always had. So, you know, to kind of have to look at what other things you needed to do to protect your staff was very, very challenging. We overcame that by attempting to get onto the government portal for support, but we didn't find much support from that, i.e. we applied and we didn't get any PPE at all. But our local hospital delivered a couple of rounds of PPE, and our local authorities supported us extremely well during that time.
Excellent, thank you, Sue-Ann. In no particular order, but it might be nice to hear from a chap. Mike Armstrong, do we have you there from Havering Care Homes?
Yes, thank you very much. I think probably early doors, the biggest challenge we had was just the plethora of guidance coming through as we're trying to, you know, decide the safest way for our workforce to work. And one of the ways we overcame that was actually the Healthy London Partnership brought together a range of people from different knowledges, from a number of different backgrounds, from Public Health England to providers to other experts, to actually start to put together a pack that could go out to care providers to help them to understand what the guidance was and what we needed to put in place. And I think for me that was a fantastic resource, along with just talking to other providers. I'm a chairman of the Havering Care Association as well, and just bringing together providers and understanding the challenges they were facing with workforce and how we work it through together.
Excellent. Thank you very much, Mike. Hanneke, you are our questioner, but you're also the area director for London region of ACAS. So maybe you can give us your sort of pan-London look across things in terms of that, the greatest challenges and overcoming them for you.
Yes, thank you. So I would say on reflection, it was the pace at which everything happened, and it was very chaotic, if you recall, with so many almost surreal situations that people were having to deal with. So the way that we overcame, those challenges in trying to get our risk assessments up and speaking to companies around London was about the need to collaborate internally, getting people from across the business to all work together to keep pace, being flexible and being willing to keep changing and updating the risk assessments with the new information and knowledge that was coming through.
Excellent, thank you, Hanneke. That's a fantastic insight. Carly, I think we're going to lose you soon, so can we go back to you and get a bit more insight for you on that big challenge and how those were overcome?
I think the biggest challenge for us right in the beginning was fear, basically. So staff being scared because, COVID-19 was new. No, there was very mixed messages with the level of PPE they needed to wear and things like that. And, people loved their jobs, but they also have family themselves. Nobody wanted to bring COVID-19 home from, working in the community to their children, loved ones with underlying health conditions, all of this sort of stuff. So it was just right in the beginning was managing fear and not losing, a big amount of workforce because they felt scared to go to work. And it was just, how we overcome that was just in real support and making sure right from the beginning that we issued every staff member with full PPE. So when it wasn't, recommended to wear a mask, we said, no, you all wear masks. When it wasn't recommended to wear the level of PPE that they do now, they wore it right from the beginning. And that wasn't just the carers as well. It was clients, carers going into their properties. They wanted to make sure that, if a carer went into another property and that person may have had COVID-19, how do we stop the spread, the cross-infection, things like that? And to mitigate that risk, we just went full PPE right from the start and gave everyone a team leader just to talk to them. And it's okay to be afraid. And, you're not bad to be afraid, but let's see how we can talk about it. Let's understand what we're doing to support you, for you to be able to work and mitigate those risks and things like that. But I think fear for us right from the off was a big challenge for our workforce and clients.
Absolutely, and brilliant to be able to go on the front foot so confidently as well. So some would argue that nationally we should have done that. I couldn't possibly comment. Aileen, I hope I got that right. Aileen Buckton, who's one of our panel members from ADAS. Can we get your thoughts on those big challenges and overcoming them?
Yes, Mike, I think what the directors of adult social services felt across London was, I think we're known in local authorities for sometimes being overly bureaucratic, and this was not the time to be that. And I think the challenge for everybody was how to support managers and staff, but at the same time, not to burden providers and not to kind of overburden providers by asking too many questions, by constantly kind of being in contact and not reacting. So it was about trying to develop something that was a flexible local response, but also making sure that we got some consistency across boroughs, because in some boroughs we were able to do a quick response on PPE, and others it was more difficult. So we tried to set up systems that would facilitate across the board, so that, providers in whatever borough you were in, hopefully you would get the same kind of response. But it's about, I think what we've learned is about establishing relationships that are more flexible and can move more quickly.
Excellent, thank you. I think something that we've seen across the board is delightful return to clarity of message and simplicity, and a bit of kindness as well thrown in as well. We're doing a grand job. We've got 4 minutes left, and we've got, I think, three of our panel left to go. So, Karen Morse, can we? Yeah, I think we've got you down here as head of area for London and the South East at Skills for Care. Can we get your thoughts on the challenge and and overcoming them?
I think early on we actually in the South East things really took off. We had an IPC network that operated across WhatsApp, and we quickly maxed out the membership of that. And in London, it was a bit different, possibly because of the measures that people have already spoken about that were already in existence that we wouldn't want to duplicate. I think that the government, certainly their risk assessment advice came very late and was quite short. So one of the big challenges really for us was marshalling all the information that we got into something sensible that people could follow. I think after that, the big challenge is for smaller organisations about where people are at risk. How do they mitigate that risk? And trying to find solutions to that, where redeployment isn't really possible. Is it a case of better training, better PPE, working in teams more effectively? So that was a big challenge, really. How do you mitigate once you know there is a big risk?
Yeah, absolutely, and it's an ongoing challenge, I should imagine.
It is.
We have 2 minutes left. I think when we've got 2 panelists left to go to. Natalie Reid, could you give us your thoughts on the kind of biggest challenges and solutions to those?
Hi everybody, it's actually Natalie Gorgo. Sorry about that. Yes, I mean, the biggest challenge was, of course.
Natalie, you're a little quiet for me. I'm not sure if anyone else can hear you a bit louder.
There we go. Is that better? Sorry about that.
Much better. That's great. Thank
you.
you.
Cheers. Yeah, just recognising the difficult position that providers were placed in, as well as family members and loved ones of people who use care services. And I think one of the earlier presenters mentioned the fear being the most difficult thing to overcome initially, and absolutely, I can only echo that. I think the just sheer number of guidance documents and the continually changing guidance documents for providers of services was also a huge challenge to overcome. And now, of course, we're seeing unfortunately, the lack of testing available to services and to people who need them, which will be an ongoing challenge to overcome. So,
yeah. Absolutely. Okay, thank you. Sorry for cutting in there, Natalie. But Sue King, last but not least, can we hear from you again from HC1 on those bigger challenges and solutions? And then I think we'll hand back to you, Bryony, for closing remarks.
Okay, well, really, I think to echo all the other sort of colleagues that have spoken so far, I think the challenges are changing, aren't they, from sort of the earlier situation where we had obviously all the problems with PPE and the anxiety associated with supply, etc. Now we've moved to obviously the difficulties with COVID testing, which underpin many of our protection prevention plans. And one of the concerns I have from sort of a health and safety perspective is that we focus primarily on sort of our colleagues and residents in our homes, but many of our services are actually supported by third parties, particular contractors coming in to do health and safety checks. And here at HC1, we've tried to ensure that all our contractors have like a passport, so they're tested monthly, and in fact can demonstrate that they're clear of infection when they come into the home. With all the ongoing issues, that's not been possible. So we are being faced now with having to relax some of those requirements, or the alternative is not to have these quite vital planned preventative maintenance checks carried out, which then impacts on the wider safety issues within the home environment, particularly those are electrical checks, if the Lola checks on hoists and slings, if in fact it's sort of a Legionella testing arrangement. So, you know, there are not only the immediate sort of concerns with regard to infection control, but the wider impact that the position is having on our fundamental arrangements for ensuring health, safety and well-being, you know, within the business.
Absolutely. Thank you, Sue. And that's a nice way for us to round off. I think the challenges continue, of course. Bryony, I'll just hand back to you briefly for closing remarks.
Wonderful, thank you so much. So some thanks, really. So thanks so much to our 4 speakers. It's been incredibly inspiring hearing how the best practice examples and how you've really made a difference for your staff. Also to the panelists for giving their time and offering their thoughts to the discussion, and to those behind the scenes who've been beavering away, keeping everything running, and also to so many people for joining and participating in today. Just a reminder that we've been recording the session, so that will be available to be shared. So in terms of, if you joined by Eventbrite, we've got your details, so you'll get that automatically. If you didn't join by Eventbrite, there is an email in the chat. You can either send your email to that or post your email directly into the chat. And thank you very much, everyone. Again, I hope you found it useful. Just huge thanks, and have a wonderful rest of the day.
Thank you.
Thank you.
Thank you.